Welcome virtually to Milwaukee.
Thank you.
Dr. Miller, are you ready for us to get going? Dr. Laird will introduce you, but just wanted to see. Oh, we got some more people.
Yeah, I'm ready. I'm jealous of your breakfast, but I'm ready.
Yeah, sorry. We'll send some smells virtually to you.
Okay.
Figured out the food virtually yet, but we're working on that here in Milwaukee. Welcome virtually to Milwaukee. Good morning, everybody. We have Dr. Miller who's going to talk to us this morning about some interesting things, and Dr. Laird is going to do the introduction. So I'll turn it over to him and we'll do our divisional M&M to follow.
Hello and welcome everybody. This is our fourth conference in our pilot joint PICU and surgery conference. It's been going really well so far. And for this one, I've invited Dr. Jenna Miller from where I did fellowship in Kansas City to talk about ECMO and pediatric sepsis. She did residency and fellowship there, and then, medical school and residency there, and then fellowship in Texas Children's, and is currently a pediatric intensivist, medical director for ECMO and professor of pediatrics at Children's Mercy in Kansas City. And I've asked her to give us a talk on ECMO approaches to pediatric sepsis. But Chris, you say, isn't there only one approach that's better than all the others, which is central cannulation? Maybe, maybe not. We'll hear it from Dr. Miller.
Thanks, Chris. I appreciate that. Yeah, so we are going to just talk about some ideas. I appreciate Chris giving me some history of your guys' program. And then I actually know Rachel too from when she did her palliative fellowship here in Kansas City, one of your intensivists. I apologize for my throat getting over a virus, but we're going to see if we can get our slides to advance. There we go. Okay, so our objectives today is we're just going to talk about some of the data by ELSO, so kind of our governing body for ECMO, and some of the literature that's out there over the past 20 years, some approaches to ECMO support, and then I'll share our center experience, which I think, isn't the same as other centers' experiences, and so I think it, obviously colors my lens on how I view this problem. So let's get into the numbers. So for those of you like a little history about what you're talking about, just one of my colleagues had this slide and I like to throw it in there just to think about, what we've learned over time and what we haven't learned over time regarding sepsis. So, the word sepsis goes back to BC, kind of 400 BC with Hippocrates, who uses the Greek word "sepsi" to make rotten. And so, what have we learned since then? A lot, but there's a lot that we still don't know. So we think about all these trials and studies that we've had over time to try to define sepsis and to come up with the smoking gun to treat sepsis. And we still, I think have a lot to learn about the treatment of it. And so what are we left with in the meantime is supportive care. And so, we have the most recent resuscitation guidelines that have come out of SCCM that do include ECMO as part of the sepsis algorithm. And so we're going to talk about the option of using sepsis in this process. And so when we go and look at the ELSO survival data, so I went back 5 years, just North American centers, and I distilled it down to this data. And so when we talk about sepsis, we're talking about this bucket here in pediatrics. It's all lumped in with cardiac. So you're going to get congenital heart disease when you look at these numbers here as well. And then our ECPR numbers we'll talk a little bit about, but I'm not going to go too far into the weeds there specifically because it's its own beast. But here we look at the survival numbers for pediatric cardiac ECMO, which is 56% and 41% for ECPR in North America for the last 5 years. But they do distill it down into just sepsis data. So that's nice for us in this talk. And so when we look at all comers over time since the beginning of data collection, we see that it's about 44%, which doesn't feel super great. But when we look at the last 5 years, we see that's up to 52%. And that, I think, demonstrates the improvement in survival that we've had. And some of the data that I'll show you from some of the other studies do distill it down into North American centers. So you can see a little bit of the difference that we get in survival when we look at a little bit more comparative peer centers here in the States. And so when we go back to think about, well, why should we use ECMO in sepsis? Why should we consider ECMO in sepsis? There are some studies that tried to look back at some of the kind of proof of concept. And so this is a binational study that was out of Australia and New Zealand. And for those who are familiar and supportive of central ECMO as a technique, a lot of the data for central cannulation comes out of this group. And so that's why one of the reasons I wanted to include this study is because it does, it comes from that collaborative group there. And so this aim was to determine the clinical benefit of ECMO. And so they had 5,000 children that they looked at with sepsis and septic shock, 80 treated with VA ECMO. And they tried to develop a multivariable mortality model. And the one that they developed actually performs better than PIM2 when we're looking at mortality. And so the metrics are there. I won't read them out to you, but pretty, I think, intuitive what they're using to develop this model. And it's interesting because their benefit threshold was found to be 47%. So those who had a predicted mortality risk greater than 47% with this mortality model benefited from ECMO, and those that had less than 47% did not benefit from ECMO. And so this is interesting because at our center, we have kind of this very quick 50-50 method. So if a kid rolls through the door in extremis, as I'm sure you've all have experienced from the ER, from the floor, from an outside institution, and to make a pretty quick determination about whether or not you think they're an ECMO candidate, we might apply the 50-50 method, meaning do we think their chance of survival from this acute problem is greater than 50%? And do we think their chance of survival from any underlying problem is greater than 50%? And then if that is a yes, then we kind of proceed with, yes, they're a candidate. And if you have time to kind of think through their underlying disease physiology more, then we will absolutely do that. But as a quick, bedside check, I was glad to see that kind of jives with this predicted mortality model. If you're wondering what I mean by 50% survival from underlying disease processes, that really was developed when we were talking about our oncology patients. And so when their 5-year survival was predicted to be greater than 50%, then we would consider that potentially a candidate if their acute process was also reversible. But we do apply that to some other disease processes as well, some chronic disease processes now, but that's where it started, was in the oncology population, where the prognosis numbers are a little bit more well-defined. So some more studies about ECMO for sepsis. This particular study is a peripheral VA ECMO, and Brian Gray is on here, and he's a well-known neonatal ECMO surgeon who does a lot of conferences and speaking about different techniques that we use in the new crescent cannula specifically. And so they did a retrospective review of 40 peds patients in 2 different PICUs. Their survival was about 52%. When they excluded their oncology patients, they were up to 62%. And I put a little blip in here about the mean pump flow rates. We're going to talk a little bit more about flow rates later, so I won't get too far into it here, but just to show that survivors had higher flow rates around 100 and non-survivors were lower around 75. This is a systemic review and meta-analysis. And so obviously, a good way to look at a variety of studies en masse. And so they looked at 23 articles, included 13. Their median ECMO duration was 129 hours. Median ICU length of stay was 13, hospital length of stay was 28. And I just put in here gram-positive organisms were about half of those patients. And there's another paper that I decided to not put in here, but just in general, when we think about staph infections, MRSA and MSSA infections, based on another paper, have similar outcomes when we look at those. But when we go to look at their forest plot, they included about 2,500 patients in here. I have a nice arrow sign for you that tells you their survival was overall 59, close to 60% when they pooled all of these papers together. They did comment that early intervention is better, which I think intuitively we all recognize, avoidance of multi-organ dysfunction is imperative, but, picking that right moment and kind of having a crystal ball to tell the future is sometimes challenging. We're thinking about the right time to initiate ECMO for sepsis and for any other etiology for that matter. This is one of the studies I was discussing where they did pull out the neonates, and they had 85 of those and show 73% survival, and they pulled out North American survivorship, and that was also 73%. So interesting, there's a bit of a geographical difference between centers, and I think, we may all recognize, centers that do more ECMO often have better survival, who have been doing ECMO for longer periods of time have better survival. And certainly we saw that during H1N1 and COVID when people stood up ECMO programs and tried to provide ECMO when we didn't have enough ECMO machines. So I think there's a lot that goes into that, but I did want to point out that, when we're compared more with our similar peer group, or not compare, but when we look at the peer group that we're probably most interested in when we're thinking about survival, it is a little bit better. So ECMO support approaches. So, we'll get into the meat a little bit about literature related to central versus peripheral. But first, I wanted to just provide two case examples that I personally have been involved in and had two different approaches. And so this was a fellow case that I had. So it was an 8-year-old who just, very innocently fell in her kitchen, had a cut on her thigh, and then a week later presented with group A strep necrotizing fasciitis, was extremely vasoplegic. And so she was cannulated with open chest VA ECMO with multi-organ dysfunction. At this time, our division director had just come from Australia. And so, this was the first open chest ECMO that they had done when I was a fellow as well for sepsis. And so this particular patient for coagulopathy used a continuous FFP drip. I think these days we may be doing plasma exchange for that. And she had just a 3-day run and she survived neurologically intact. She lost a couple toes, but she was doing well. And then here's a case example from my faculty life. So this is a 9-year-old, 22-kilo MRSA, ARDS, and sepsis patient who was peripherally cannulated with a 14 French arterial and a 21 French venous. He was extubated, as you see here. I'll play a little video for you in a second. He received a corsaplex, CRRT. He was found to have pulmonary artery aneurysms that required interventional cath for coiling due to severe bleeding. He had a 60-day run. Now, obviously, most of that was related to his lungs, and his sepsis had resolved early on. But he was a very long VA run, and he survived neurologically intact. So I'll just share this little video of him extubated. This was after his sepsis had resolved and his cardiac function was improved, but we were just waiting on his lungs. And so we called this rock therapy. So you can see he's painting rocks. I don't have the sound on, but he's listening to rock music and kind of singing along with that. So we were able to do some good awake time and physical therapy for him while we were waiting for his lungs to recover. And so, two, similar physiologies in that they started out with sepsis, staph and strep, but different approaches to their cannulation strategies and both with good outcomes. So I am not, the technical expert in inserting cannulas. And so I appreciate our surgical colleagues for their expertise in this. But while we're getting to the literature, just wanted to give a brief overview in peripheral and central VA and kind of the benefits and challenges of both. Peripheral cannulation, most commonly in peds, I think we're talking about neck cannulation. Obviously, we can do some fem. I think that is more challenging, obviously, in our cohort of patients due to size and flow needs. But certainly, I think there's room for us to have more discussion about that, because this is really essentially all our adult colleagues do. And they kind of look at us funny, like when we're talking about cannulating in the neck. But those are our two most common approaches, obviously surgical versus percutaneous, and then the small babies most commonly surgical. Advantages to this is we avoid the sternotomy and the risks that go with that. Can be a little bit more wakeful because we're not worried about these, cannulas popping out from a central approach. I put increased number of cannulators here just as kind of a thought about resources and availability of people to cannulate. Obviously, when we're doing central cannulation, we rely on our expertise of our cardiac surgeons. When we're doing peripheral cannulation, our general surgeons can assist with that. There are some centers where the intensivists will do percutaneous cannulations, and if our adult colleagues, where they're doing mostly fem percutaneous, they have ER physicians who are doing their cannulations. I'm not proposing that we necessarily do that, but just to kind of give a spectrum of the smattering of those who can cannulate when we're talking about peripheral. And then the challenges with that, obviously, we are faced with small vessels in our patients with, the flow limits that come with that. And when we're talking about sepsis, that is a big challenge because, as we'll see, flow is probably the big driver. And so we need high flow with especially sepsis. And even in other physiology, the flow limits may be, prohibitive if we have small vessels. Limb ischemia, again, we don't do fem quite as much, so we don't see that nearly as much or have that concern nearly as much as the adults. And then if we have to have LV unloading for LV stasis and severe LV dysfunction, that's often another trip to another place with the cath lab or surgeons to help with LV unloading. So central VA, obviously, we're talking about aortic root right atrium. It's an open chest approach. the benefits are really recognized to be that we can probably get higher flow rates and we have increased ability for cardiac unloading. So hopefully lesser need for LV specific unloading, but again, kind of right there if we need to do vents or any other procedures to help with LV unloading. The challenges are bleeding, infection, and then sedation. Obviously, they need to stay pretty still and quiet throughout that period of time. And so, we like to do a lot of awake ECMO here if we can. And so that, is a risk benefit and a balance for which approach to take. And so getting into some of that literature. So central ECMO for pediatric septic shock. So again, around 2010, the Australian group put out several papers about their experience using central cannulation for shock and showed really good outcomes. And so people thought, gosh, this is the way to go for sepsis and if we want to have good survival. And so they did, this particular paper was 23 patients. It included 11 from their previous report. And so they titrated their flows to normal blood pressures and basically reversal of their multi-organ dysfunction. And they showed, there's a lot of business on here, but what I wanted to show is that they really had really high mean inotropic scores. When we look at the entire group over there on the left table, they used high flows, which I think is what we would expect from central cannulation. And so we look at the weight and the flow range in the middle table there, and we're talking about potentially 150 plus. They didn't break it down for us exactly, but 150 plus potentially for flows. So certainly probably above that 100 where we might all shoot when we kind of initially get on pump and then work our way to wherever we think we need to go. This table over here on the right bottom, I pointed out because they compared survivors and non-survivors, and there's generally minimal difference when we look at p-values. If depends on how you believe in p-values, and some people, are very strict about p-values, and some people think it's just a number. So I just wanted to point out the differences there. So the lactate's the only one that is statistically significant, and that I think is easy to understand. The mean inotropic scores is not statistically significant, but interesting, the difference is, 60 in survivors and 144 in non-survivors. So clinically, that feels like it might feel pretty different at the bedside. And I will kind of point that out in a couple of places, statistically versus clinically significant, in your interpretation of that is your own, but I think that might feel a bit different at the bedside. So the non-survivors, I'm not sure if they were really sicker or not, but this might feel different at the bedside. So again, this group put out several papers around 2010 that really talked about central ECMO as potentially providing, better outcomes for sepsis when we were looking at this really sick population. Sorry, I didn't even get into the results. So in the results, 78% survived to decannulation. So that was pretty unheard of when we were talking about most things in ECMO, actually, but certainly when we're talking about sepsis. The couple that didn't survive, one did make it to decannulation, but then died later. And then the couple that died within 24 hours of cannulation. They had a 30% re-exploration for sternotomy site bleeding, but had no mediastinitis. So that was really great to see. So does flow matter? I think this is kind of gets to the heart of the conversation. And so this particular study looked at conventional therapy versus VA therapy. And so kind of, again, more of a proof of concept discussion. And so when we think about the adult trials that went and looked at ECMO for more A or DS type physiology, and we think about Caesar and Eolia, and we look at that. This is a little bit, I think, similar for our pediatric patients, and we just so rarely get studies that look at our pediatric specific patients and our pediatric physiology in a head-to-head comparison. So this is a nice study. I think it was published in 2020, and it's multinational again. They had a 40% survival in their severe septic patients without ECMO, and then they had 50% with ECMO. So that was not statistically significant. Again, we'll point out that, I would take a 10% survival benefit in most of my pediatric physiology that has high mortality rates. So, you can take that for what it will. But there were several, when they broke down subsets for analysis, there were several other things that stood out. One was that ECPR and cardiac arrest, a clear benefit using ECMO, which I think makes sense to us with a 40% versus 18% survival. And then the table that I showed here on the right is the conventional therapy in the dark box. The middle is a standard flow, which was defined as less than 150 per kilo. And then the right is the high flow, which is defined as 150 and higher. And so when they broke it down to standard versus high flow ECMO, they did see that the survival benefit was 80%, or they had 82% survivors in the high flow ECMO group. So the N is probably on the smaller side there. However, I do think it demonstrated a nice difference when you looked at, all ECMO is potentially not the same. We call for ECMO and we all sweat it out until we get on pump, and then the entire team, bedside surgeons, ICU docs, nurses, everyone in there sighs a moment of relief, like, oh, we are now on ECMO. This is great. We made it. What happens when we get on ECMO, I think is just as important and interesting to think about after that, so that we can try to achieve some of the better outcomes. And so this particular study shows kind of flow as being really important. And so Dr. Laird provided me with your guys' cannula chart. So you're not going to see all the little nitty gritties of this, but I just threw it up there to show what it looks like. Over there on the left, you have patient weight, desired flow, and then size of cannulas based on what site you're going to. So from what I can determine from this, it looks like kind of baseline shooting for 100 per kilo based on weight, and then kind of going from there when you're picking cannulas. Certainly when we're talking about sepsis, we're interested in probably greater than 150 per kilo in flow, or at least considering, do I need to get up to 150 plus in flow? And so similar to our single ventricle patients who kind of have parallel circuits and need higher flow, septic shock is similar. So I threw up, our, expectations for the less than 20 kilos. For greater than 20 kilos, we would probably start to talk about cardiac index in addition to per kilo flow. But for simplicity, I threw this one up here. And so, again, when we're thinking about septic shock, we would think, what do we need for flow for this particular patient in order to potentially meet their sepsis demands? And then look at our max flow rates by cannulas, and have a conversation with our surgeons, based on that patient's physiology, ultrasound data, if we've got it, and what we think we might be able to get in there, and, pull what we hope to get for flow rates in order to achieve desired flow for that sepsis patient. And then obviously a couple of smaller ones, depending upon what it looks like when our surgeons get in there, and they will obviously help us decide which cannula may fit, but we will shoot for the biggest one we can get in order to achieve that flow of 150 plus. So here's a case example of a recent kid that we just did in January, who's a 5-month-old with propionic acidemia, 10 kilos. We did her peripherally, and so she was a 12 arterial, 15 venous cannulation. And when she was cannulated, we weren't sure if it was sepsis, metabolic crisis, a little bit of both. And so when we put her on, we knew we were probably going to need high flow rates. And thankfully, we were able to get around 200 per kilo of flow for her, and she needed every bit of it. She ended up doing a round of CRRT and Plex, and in the midst of this realized that she was probably more of a metabolic crisis, and so kind of treated her as such with, high CRRT clearance rates, and that was able to help turn her around. And so she survived after an 8-day run. If we were not able to provide her with 200 per kilo, I don't think we would have been able to support her well, and probably would have had to add an additional venous cannula. We have, I've been at Children's Mercy for 12 years, and I think there's been 1 or 2 times that we have considered central cannulation for sepsis. One, we were not able to get transition from peripheral to central in time, and one, we ended up not needing it. But generally speaking, we've been able to flow high enough to, I think, mimic what people get from central cannulation to be able to support these patients. I'll talk a little bit more about that later. So this is a paper that just came out, and this paper probably doesn't jive with my personal, not my personal approach, but our program approach to these patients. But I wanted to share it because it's new, and it uses ELSO data set, and just trying to obviously present all the data. So this particular paper came out in January, and so it was 1,200 patients out of the ELSO database. 1,000 of them were peripheral, and around 100 of them were central. Mortality was 55%, so a fairly high mortality. That doesn't feel great. But again, remember when we were looking at ELSO data in the last 5 years, we saw that survival improved in those last 5 years. So this particular cohort captures that kind of a broader timeline. And so our median pump flows at 4 hours is around 100 and pretty similar at 24 hours. So again, on the lower side for what we might think we would need for sepsis. And so when we take the results into account, I think we also need to think about the fact that the patients were provided with or the patients were supported with flows that for some may not have been enough, and so that could have been part of the issue. But when they look at multivariable regression analysis, higher flows were independently associated with lower odds of mortality at 4 hours, which I think makes sense to people probably. But when they looked at head-to-head comparison of central versus peripheral, the survival rates were higher for the central patients. There were complications in both groups. The peripheral groups had higher vascular complications from limb ischemia in the femfems and bleeding, but had lower length of stay and cannula site bleeding. And then the clinical implications are that they thought that the central VA ECMO made better support patients in pediatric shock, but that the choice of strategy really should continue to be individualized based on the center, the patient, severity, illness, and obviously the anatomy. So I'm going to leave you with this, thought as we go into some discussion about center-specific experience that we have. So this is CICU included, and I have a picture of our pump there. I don't know if there's any bedside folks there, but we run the Spectrum pump. And then we obviously have the same oxygenator issues that everyone else does. And so we run with the Nautilus on the big kids and the Abbott on the smaller kids because of air handling issues. If anyone has questions, happy to share about that. But this is also a picture of our CRT circuit in tandem with our ECMO circuit. So a little bit about our center, just if you're wondering, what is their experience and why do I want to listen to what that might be? And so we're a Platinum Center of Excellence. And so have had that for 2 or 3 cycles now. And then in 2021, we provided ECMO to our 1,000th patient. So, the history of ECMO is not so long that any one center has a huge cohort of patients. And so that was several years ago that we were able to support our 1,000th patient, and then obviously have continued since then. So really a nice history, I think, in the center. Obviously, it began with neonatal, as many centers did, added cardiac, and then added PICU later on. So overall data, I'm showing this again, and this is all comers for ELSO when we're talking about pediatric and cardiac. And then I just wanted to put ours next to it just to show you again for all comers in this middle section here, which was what we're talking about. Again, this is lumped with congenital heart disease in this particular screen. So take that with a grain of salt, but just to show that our outcomes are comparative or sometimes better depending upon the group that we're looking at. Going and looking at our data a little bit more granularly though, when we're talking about that. Oh, was there a question? No? Okay. Sorry. Looking at our data more granularly when we are thinking about particularly sepsis and our general surgery patients, which do our NICU and PICU patients. So taking out the congenital heart disease patients, a quick snapshot of what that looks like. So over there on the left, the yellow is NICU and the green is PICU. When we look at the last 5 years, we have all patients. We have 99 survivors, and so that is about 69-70% survival. Breaking it down by unit, NICU is 72% and PICU is 66%. So I think when, like I said, breaking down to just the patients that would probably be most likely to represent sepsis patients, obviously our cardiac patients have septic shock as well, but more likely to represent our sepsis patients. That is a quick snapshot of what that looks like. And then when we look at cannulation type, VV is probably less interesting for this particular talk, however, have good outcomes there in VA, 67%. I mentioned, adding venous cannulas, but very rarely have we had to do that. There's only one listed here in the last 5 years. We did one subsequent to when this data was collected this year, but rarely are we having to add venous cannulas, but certainly will if we need to increase our flow. And then over that time, we only had 2 VV to VA conversions that were necessary for those patients. We've done 25 eCPRs and have a 40% survival there. So I think that also is pretty respectable when we're talking about eCPR outcomes. So really appreciate kind of our entire team approach to this with our general surgery expertise, our bedside specialists. And so we have a core team, which is our in-house primers, and they have a wealth of knowledge. None of them until recently had less than 10 years of ECMO experience. And so I think they also contribute a lot to what we have for expertise at the bedside. So this is our flow characteristics for our sepsis patients since 2015, so really over 10 years. And so in the middle here is 100 and 150, and that's kind of what we've been talking about as where do we need to be for sepsis? You can see, obviously, we have some patients that are up here at 150 and above, and our median line there is probably around 125. So we're able to support some of these patients with less than that 150, but certainly plenty of them that are near or above that 150 as well. And the different line, is the blue is at 4 hours and the orange is at 24 hours after initiation of ECMO, which is what's reported to ELSA. So it's the most easy data to pull, and why you'll see those timeframes when people are reporting out their statistics most commonly. This is sepsis 24-hour flow and survival. And so I think this is interesting to look at because we're talking about flow is important, and flow should be, a determiner for survival. For our own personal data, in the last couple of years, I think over here on the right-hand side of this graph probably is more indicative of what I would think I would see, which is that, higher flows equals, higher survival, and or more survival, and lower flows is potentially associated with lesser survival. But, in the earlier days of when we were doing this, and I think, even 10 years ago, the way we practice is very different than how we do now. So, I take a little bit of that with a grain of salt. However, wasn't necessarily what I expected to see when I looked at our data. But again, in transparency, wanted to kind of share that with you guys when talking about our approach and our outcome. Let's see, how are we doing on time? Okay, good. We should have time for some questions. Okay, and then I brought this chart in. This is from the last paper that I was reviewing in Central versus VA, meaning the most recent paper that came out about that head-to-head comparison. And the top chart here is odds mortality at the 4-hour mark. And so as we go up here on flow towards the right, the odds of mortality are lower. And so that makes sense to us in this conversation that we have. The higher the flow, potentially, the better supported this patient could be. But then we come down here to this lower chart at the 24-hour mark. And as we go up to over here with flow, there's more mortality. And so I was like, make it make sense, and so I've been thinking about this, and especially in the context of giving this talk. And so I show this because one additional adjunct that we use for these patients that I think is worth mentioning, and it potentially affects the outcomes of what we are seeing, is the use of Plex in sepsis patients. So I didn't have time to do a full, case or literature review here for you for the use of Plexus in sepsis patients, but listed a few studies here, and they're particularly associated, or not particularly, but a couple of them are directed at TAMOF, so thrombocytopenia-associated multi-organ failure, which is an indication in the apheresis literature that has pretty good evidence behind it. And so commonly with our sepsis kids, they will be thrombocytopenic and have multi-organ dysfunction, as I'm sure you guys have had experience with. And so we will use Plex as an adjunctive therapy to assist with these patients. And so just briefly, a couple of these studies show that they had lower mortality, lower organ dysfunction rates, and had reasonably good survivorship with 71% in that second study there. And the bottom is a case series of 3 where all 3 were survivors. And so, obviously the people who are having good experience with it are sharing about it, but a couple studies here that show or discuss the use of therapeutic plasma exchange in sepsis, multi-organ dysfunction, and or TAMOF, and that it could be a tool to add as an adjunct to our ECMO support while we're trying to get these patients through this. And it is, I will admit it is a hammer. We're not necessarily targeting any particular cytokine, chemokine, inflammatory pathway, but resetting the whole thing, since we don't know what the particular targets are by patient. So in summary, that'll be good. We'll have a few minutes for questions. I think there is a role for ECMO in pediatric sepsis, and outcomes are improving. There has been certainly some literature to say that there has been historical difficulty with this, but I think as with many things in ECMO, we're making strides. The best cannulation strategy, I use quotes in parentheses, is likely still probably center and patient dependent. I use a lot of peripheral for sepsis, but if I thought I needed central, I would absolutely still, ask our cardiac surgeons to help with that if that was something that we thought was going to be beneficial for the patient. Flow is probably a key driver. Again, not an absolute, but especially in those vasoplegic patients, getting higher flows is probably going to be more helpful to support them, especially in early times. And then Plex can be a tool to potentially support these patients. Again, depends on your center's experience with that and how, you can hook in with Tandem, but potentially that could be helpful to these patients. And so with that, I will stop. So if there's any discussion, I know you probably all are busy and need to run off, but wanted to have a few minutes for questions.
Dr. Miller, thank you.
You're welcome.
So I'm in the room, Chris, people trickled in as you got started. So just so you know who heard your talk and who questions may be firing from, we have a bigger crowd, I think, than Teresa suggested we might over the email, which is great. But we have our whole division, we have our fellows, residents, on-service medical students, our advanced practice PA team and MP team. We have several of our colleagues from pediatric critical care. I see a handful of our attendings and fellow colleagues from that are your more immediate colleagues, and then a few of our faculty had to run off to get things started. And speaking of, there's an ongoing ECMO decision over a DH patient that's happening in the background of our conference right now, amongst our team and our NICU team. And so that's who is in the room here. Might be firing questions. I want to open it up. I do have a question for you, but I wanted to see what others thought. Well, I can get it. Go ahead.
I have a question. Thank you very much for your time and this great talk. Are there any data that focuses on size, like obesity as a risk factor for obtaining these high flows? Because we vessel size as having a more linear relationship with age more than weight. Mm-hmm. So I feel like getting these high flows in a young child that's size appropriate is going to be a lot easier in the peripheral cannulation than what it would be with a teenager that's obese. So getting 150 milliliters per kilo per minute on a 100 kilo child can be significantly challenging for peripheral cannulation. The same flow can be much easier to achieve with peripheral cannulation in a non-obese patient.
I fully agree with you. I think obesity, presents challenges for ECMO as well as many of our other ICU cares that we're not as equipped to deal with as our adult colleagues. When we are talking about patients that are bigger, we may convert to kind of cardiac index to see if there's a cardiac index that we might be able to support with those cannulas. And also consider what ideal body weight for that patient is. Obviously, when you guys are in there cannulating, vessel size isn't necessarily equal to, habitus of 100 kilos, right? So I think that point is well taken. And certainly we've had some challenges with cannulations, peripheral cannulations in our obese children. We've done a handful of them, and it's probably been 50% successful and 50% not in just, ability to get good cannulas in those patients. So I think that is a unique challenge that I very much recognize could be even more challenging when we're talking about peripheral cannulation. However, again, I would probably shoot for more of a cardiac index idea than a per kilo flow goal in that particular patient to see if it was even feasible for their peripheral. But yeah, completely valid to be more concerned about whether you're going to meet the demands in the bigger, especially obese patient where you're not completely sure where ideal body weight may land or may lie, such that your flow would be meeting that.
Jenna, it's Rachel. I was just wondering, you talked a little bit about wanting to get in early before organ dysfunction and before you start to see complications from the sort of under-supported, under-treated sepsis itself. I think one of the things that I have always struggled with at the bedside, and I know some of my other colleagues have as well, with with ECMO for respiratory status, I feel like we have, although not criteria, more solid things to follow in terms of looking at, have we seen improvement in our OI over, X number of hours with the current support, and what other options do we have? And while we certainly look at the number of vasoactives that we're on and the dose of those vasoactives, is there anything that you use clinically when you're at the bedside making this decision with your team to move forward with ECMO in a sepsis patient that you have found to be sort of a helpful guide as we might use OI in respiratory ECMO?
Yeah. I don't have a smoking gun that's a number or an equation that your EMR can spit out for you, but a couple of kind of I guess not ground rules, but guidelines. So one, we have a regional ECMO referral tool that we just developed. And so that is for our, we have a large encatchment area. And so for the centers that are outlying that don't have ECMO, to try to get the patients to us in a timely manner, this is kind of the beginning of the answer to your question. But when we get to epi and norepi of 0.1 and 0.1, we're like, please get them here or refer them here so that we can try to get them on or assess if we need to get on in a timely manner. So I think that's one trigger point of, if you haven't already determined if the patient's a candidate, to think about if they're a candidate. And you may have a slightly different idea about what that number is, based on your unit. But generally speaking, if we're on triple inotropes, we call it, so norepi, epi, and vaso, and we see either or both continued drop in our base deficit and increase in our lactate. Certainly as we approach a pH of 7 and sub 7, that's kind of a go. And or, we're seeing evolving multi-organ dysfunction such that, our AKI is worsening. We may have hepatic dysfunction. Are we seeing worsening evidence of neurostatus? If they're weak enough to even have any idea about that. And so I think, again, that's not, a moment or a equation, but probably how we think about it at the bedside. If we're on all three and our pH is still drifting towards 7 and a base deficit is not responding to that, even if we may see a little bit of bump in the blood pressure at bedside or what have you, if that's the case biochemically, and then again, looking at our multi-organ dysfunction or end organ signs, and or kind of either one or both would be a sign for us to cannulate at that time.
Question for you, Dr. Miller. My question is, do you think, because this was sort of a line that I saw through your talk, but didn't totally flush out, and I'm curious what your thoughts are. I'm not sure there's going to be specific data, but I'm interested in your opinion about, do you think that flow rate, once you go on ECMO for sepsis, is an independent, let's say, goal to target in sepsis therapy, apart from the other sort of well-accepted goal-directed endpoints of sepsis therapy from a critical care perspective? And I mean that from the point of you can take it all the way back to Manny Rivers and goal-directed therapy, and like we thought like a lot of fluid was good, and it turns out maybe you just need enough fluid to reach certain endpoints, be it SpO2 or urine or lactate or cardiac index or you name it. And then I'd say that's sort of how I would conceptualize like critical care support for sepsis, apart from the source control considerations. And do you think that flow rate on ECMO is somehow different or in above that, or do you only need enough flow to reach those sort of well-accepted goal-directed endpoints, and that you're really sort of looking at covariates in a way? Like, is flow a biomarker for reaching these other well-accepted endpoints, or is flow its own thing? The reason I asked that question in my last thought is, you know, I was very much raised in training, in my fellowship training, that sepsis patients need central cannulation because you need 150 to 200 flows, because that is how the physiology works, full stop. And I think what you notice, and what a lot of us sort of see clinically, is that you could periphery cannulate these patients. Like your sepsis data you showed that showed the flow at 8 to 24 hours suggests that a lot of these patients are not actually at 150 or higher, 200, whatever it might be. And we know that you can achieve 100, 125, 150 per kilo peripherally most of the time. Jose's question was great about the weight, but like most of the time you can do that peripherally. And is that enough? You know, do you need the high flow? Do you need central cannulation? Do you need any of these things?
Yeah. That's a great question. I think not gonna dodge it, but I'm gonna say, you know, it's patient dependent. So some of these kids we put on and they are profoundly vasoplegic, right? I'm sure you've seen that, where no matter how much afterload you throw at them, they are still vasodilated. And those are the kids that I think are gonna benefit from being able to have the capacity to flow higher of 150 plus. But to your point, they don't all need it. And I think when we're looking at all this data, and yes, that is a theme throughout, but I think a lot of the studies lumped all sepsis together, right? Which we know is not the case. Like, all sepsis doesn't equal all other sepsis. So I do think in some patients, and maybe many patients, they can get away with less than 150, and you do titrate to just enough. So am I at the bedside saying, no, you have to push up to 150? Absolutely not. I'm pushing up to, where are we getting good maps? Where are we clearing our lactate? Where is our AKI seem to be improving? Where, we try to wake them up pretty quickly, but where are we starting to see, mental status improve? And so absolutely agree with you. I think it is patient dependent. Not every single patient is going to need 150 plus. But those patients that are really vasoplegic, I think do, especially early on. And I'm going to, again, put my own program bias in until I plex them, and then their needs come down. And I don't need 150 plus. Early on, it's not always completely evident who's going to need that or more. And so I think, thinking about having the capacity to do that with your cannulation strategy and your cannulation size is important. But does every patient with sepsis need that? I don't think so. I would agree with you.
Great. Thank you so much.
Never mind.
Oh, Chris, yeah.
Is there time for one more question, Brian? Or
Yeah, please.
to expand on that, because I've always been kind of interested in this different kinds of sepsis, and kind of lump them all, but there's different phenotypes for sure. And there was some thought out there, and again, this is asking your opinion, not actual data. Is there some role for like echocardiogram before deciding which patient is going to get which kind of ECMO, whether it's point of care or official ultrasound, to say like, oh, this is a patient who's having severe cardiac dysfunction, and maybe they could get those numbers through peripheral cannulation, or they're a high output or high demand, or it's working okay, and it's actually just complete vascular collapse, vasoplegia, whatever you want to call it, and then this is someone who maybe needs central cannulation. Do you have any thoughts about trying to stratify those patients before that decision is made?
I think it's an interesting question. Wouldn't necessarily employ it in our particular system. However, when you ask that question, I think about, our burn patients who have a lot of different types of physiology, and we make our decision about the way we support them with our echo data. So, are we looking at a hyperdynamic, underfilled, potentially heart that potentially would lead us to believe that we could have more vasoplegia type physiology? Or are we looking at, a poorly contractile heart that, we talk about cold shock, is more consistent with cold shock, and lower flows may be very reasonable in a peripheral cannulation strategy. So I think you could use that data in conjunction with your physical exam, obviously, to kind of decide which type of phenotype you may be in. And obviously that can change, right? So, we have seen kids go from one to the other, but in this setting, it may not change fast enough that, it would necessarily change your cannulation decision. But I do think you could use that, if you guys are, trying to, determine central versus peripheral, and you guys are really good at central, and that's kind of been your practice, and people are very comfortable with that, deciding which patients to deviate from that, is not a small thing. Anything that is comfortable in your system is something that takes thought around, how do we deviate from that? So I think, Chris, that's a really interesting question and could be very valuable as far as, if you have the time to add that to the clinical picture that you're seeing, and looking at the heart and seeing, is this hyperdynamic or is this poorly contractile? Maybe that helps you decide the patient that could potentially, do well with peripheral type of flows, and may not need that 150 plus. Again, probably want to have the ability to get up to 150, but they might not need it.
Can I ask one more question?
Yeah, please.
I'm one of the critical care fellows. This is maybe a little bit more of a style question, but I'm wondering, with you guys being a high ECMO utilizing center, on your patients who have a high VIS, maybe are on stress dose steroids, you're at the point of talking about ECMO, do you give a try at utilizing methylene blue or hydroxycobalamin before you commit to ECMO?
I generally don't, and that's only because of my own bias that I've never seen it work. Okay, so I know there's literature out there that it does, and I've tried it pre and post pump just to see. I've actually tried it on ECMO a couple of times just because of patients like this who are so vasoplegic, to try to get any additional benefit. And again, it's personal bias and anecdotal experience that I've never seen it work. So it's not usually part of our my group's algorithm to try beforehand. But in the NICU and CICU and our PICU, we've tried it at different times anecdotally, but I wouldn't say it's part of kind of a stepwise approach that we would do it consistently, if that makes sense.
Yes, thanks.
I think that's a good place to end. Thank you, Dr. Miller, so much for your time. Thanks to everyone for the great discussion and questions, and safe travels back to Kansas City from virtual Milwaukee.
Thank you, guys. I appreciate it. Hope you enjoyed your breakfast and at least, food for thought for your program. So I appreciate the opportunity to dialogue with you.